Hi, I'm Ken Colley, Director of Medical Affairs for Diadexis. Today I'd like to give you an introduction to the plaque test for LP-PLA2. The Diadexis plaque test for LP-PLA2 is cleared by the FDA for the quantitative determination of the enzyme LP-PLA2, which is lipoprotein-associated phospholipase A2, in human plasma and serum, to be used in conjunction with clinical evaluation and patient risk assessment as an aid in predicting risk for coronary heart disease and ischemic stroke associated with atherosclerosis. We're going to go over some key learnings today. And we're essentially breaking this into 4 sections or chapters. First, a little bit of background and mechanism of action on this enzyme. Next, some clinical and epidemiologic evidence. Then some prognosis and treatment recommendations. And finally, therapeutic intervention. A little bit of background. Heart disease is the leading cause of death in the United States. Stroke is third. What's interesting here on the right panel is that heart disease is also the leading cause of death in women. In fact, stroke kills twice as many women annually as breast cancer, and heart disease kills almost 8 times as many women annually as breast cancer. Coronary artery disease is often called the silent killer. It was found in a study that 62% of men and 46% of women presented with myocardial infarction, MI, or death as the initial presentation that they even had CAD. Herein lies the problem. Measuring total cholesterol and LDL cholesterol are very important to do for your patients, but they don't tell the whole story. In the Framingham Heart Study, 26-year follow-up data, several interesting things were revealed. First, 35% of persons who develop CHD, coronary heart disease, have total cholesterol of less than 200. Next, 80% of the MI patient population had similar cholesterol levels to those who didn't even have an MI. Also, the median LDL level in CHD was only 150 milligrams per deciliter. Also, as little as a quarter of premature CHD is attributable to elevated LDL. Let's look at some data showing the prevalence of modifiable risk factors in over 87,000 patients across 14 studies in patients with established CHD. What you note here is over 37% of those have multiple, that is 2 to 4 modifiable risk factors. These are precisely the patients that the plaque test can help the most. Based on traditional risk factors, most of these CHD patients are still classified, or not even classified, as high risk. We don't want to let these patients slip through the cracks, and this is what the plaque test can help them with, to uncover hidden cardiovascular risk. Despite some common beliefs and misconceptions, rupture-prone plaque, not severe stenosis, causes most acute MI and cardiac death. As you can see here, over 3/4 of cardiac events are due to plaque rupture, not severe stenosis. I'm going to show you some diagrams, some schematics of vessel cross-sections that show that stenotic plaques can be either stable or unstable. On the left, you see an early plaque diagram. The lipid pool is rather modest, has a pretty robust fibrous cap, and LP-PLA2 expression is pretty minimal. That can go on to either become a stable plaque, which has a thicker cap with a small necrotic lipid core and still fairly modest LP-PLA2 expression. Or it can go on to become a rupture-prone or even ruptured plaque, where the cap is thinned, the expression of the enzyme LP-PLA2 is quite increased, and the necrotic lipid pool is much larger. And of course, that can go on to actually rupture and form a thrombus, occluding the lumen of the vessel. Let's take a closer look at this. On the left, we have the stable plaque. On the right, the ruptured plaque. The stable plaque, again, has a very thick fibrous cap, minimal necrotic lipid pool, and a fairly modest amount of the enzyme. On the right, the ruptured plaque has a very thin fibrous cap, a large necrotic lipid pool, and significantly increased amount of the enzyme LP-PLA2. In addition to these schematic diagrams I just showed, here's some real pictures of actual cross-sections of vessels from coronary arteries taken at autopsy. This is immunohistochemical staining for the enzyme. At the top left, we see the early plaque with a lipid pool that's fairly modest, as I said, and a thicker cap. As we progress, there's a thinning fibrous cap and a smaller necrotic lipid pool. This is the stable plaque. But as disease progresses, and you can see the staining becoming enhanced, staining for the enzyme, this is the rupture-prone plaque. The lipid pool is quite increased, and the fibrous cap is thinner. Finally, the ruptured plaque has thrombus in the lumen, and you can see enhanced staining for LPPL2 throughout the entire plaque, the lesion, and indeed the entire cross-section of this vessel. LPPLA2 is strongly expressed right within the atherosclerotic plaque, as I mentioned. You can see by the dark red staining that it's in the necrotic lipid core. There's a thin fibrous cap, and under it in the shoulder region to the upper right of this lesion, there's also enhanced staining of the enzyme. The shoulder region is important because that's the area of the thin, under the thin fibrous cap that's most likely to rupture. Now that we've taken a look at unstable plaque and LPPLA2, let's take a look at its mechanism of action, a little molecular biology here. First, cholesterol and oxidized LDL enters the vessel wall from the circulation. It moves from the lumen, as you can see in the upper left-hand corner of this diagram, into the intima of the vessel wall. Next, the LPPLA2 enzyme residing there acts on that oxidized LDL. It hydrolyzes it, uses it as a substrate, hydrolyzes it, and it forms lysophosphatidylcholine and oxidized fatty acids. These products act as second messengers to stimulate several further events. They cause upregulation of adhesion molecules on the lumen surface, as you can see, which attracts circulating inflammatory cells, such as monocytes. They also stimulate local macrophages within the tissue. These activated macrophages go on to form foam cells as they take up lipid in the lesion. These activated macrophages also express LPPLA2. This causes a vicious cycle and a positive feedback loop. In fact, about 80% of circulating enzyme in the body, the LPPLA2 enzyme in the body, comes from these activated vascular macrophages. The growing rupture-prone plaque includes a growing necrotic lipid core, and it also has a thinning fibrous cap. The vicious cycle continues. Now let's take a look at some of the clinical evidence and epidemiological proof of the utility of the plaque test. LPPLA2 is specific to vascular inflammation and has lower biovariability than other inflammatory markers. In the panel on the left, you can see that 40%, more than 40% of healthy individuals were found to have an elevated CRP, while only about 4% of healthy individuals had an elevated plaque value. The CRP value being elevated could have to do with systemic inflammation, arthritis, infections, and other systemic illnesses, whereas the plaque value is very specific to vascular inflammation. The slide on the right speaks to minimal biovariability in the plaque value. Across several weeks, one individual might have about a 10% variability. This is comparable to other common well-known lipid markers, as you can see, whereas CRP has over a 40% variability within that individual over those same weeks. There are more than 25 published studies showing that elevated LPPLA2 is associated with a doubling of cardiovascular risk. Even after adjusting fully for all the other traditional risk factors, having elevated plaque values doubles the relative risk of someone having a heart attack or stroke. Here's some important data from the ERIC study. Let me take a minute to tell you about the ERIC study. ERIC looked at over 14,000 relatively healthy individuals. These persons were followed for about 6 to 8 years for a first cardiovascular event. This was a pivotal study, by the way, for the FDA clearance of the plaque test for both MI and stroke risk prediction. In MI, as you can see on the left, the combined elevated plaque plus CRP values demonstrated more than a 4 times relative risk increase. Even more markedly is the panel on the right demonstrating greater than a 5 times relative risk increase with low CRP and more than an 11 time relative risk for stroke when both LP-PLA2 and CRP were high. In summary, LP-PLA2 in combination with CRP demonstrates an increased clinical utility. Here's some more clinical evidence from the Malmo study. This is a study that looked at over 4,400 non-diabetics for major adverse cardiovascular events over 10 years. This demonstrated that persons with high plaque values but not metabolic syndrome had about a 40% increase in risk ratio for cardiovascular events. This is about the same risk, relative risk, as for those persons with metabolic syndrome but low plaque values. When they had both high plaque values and metabolic syndrome, they again had a doubling of risk. Let me give you some stroke statistics, since I said that the utility is even more enhanced in stroke. Someone in the U.S. dies every 3 minutes from stroke. Stroke is the leading cause of disability among adults in the U.S. 1 out of 3 strokes occurs in people between the ages of 45 and 65. More than 4 million people in the United States have survived a stroke and are living with the after effects. 90% of stroke victims never completely recover. 40% of stroke victims experience moderate to severe impairments requiring special care. And about a quarter of stroke victims will have another stroke within 5 years. Now, cholesterol is not a reliable predictor for stroke. Cholesterol doesn't tell the whole story, as we've said, for heart disease, but especially in stroke. In stroke, cholesterol levels are completely non-associated with stroke risk, as demonstrated throughout these 6 studies. Again, this is where the plaque test finds its utility. Again, from the ERIC study, LP-PLA2 increases risk of ischemic stroke at all blood pressure levels. As you know, systolic blood pressure is a strong, independent risk predictor for ischemic stroke. Now, looking at these elevated plaque test values, it shows a doubling of risk at every level. Note the risk step up for each tertile of blood pressure. Also note the equivalence of risk, about 3.5 times, of high plaque with nominally normal blood pressure. Again, this is about the equivalence of having a blood pressure of over 130 without the high plaque level. Also about 3.5 times relative risk. I've shown you some molecular background and some mechanism of action background on LP-PLA2 enzyme. I've also shown you some clinical and epidemiological background. Now I'd like to show you some implications toward prognosis and treatment recommendations so that you can begin to use plaque test in your clinic today. There was a key consensus panel recommendation published in 2008 that recommended incorporating plaque testing into cardiovascular disease risk assessment guidelines. It was consistent with the ATP3 guidelines, in fact, suggesting that bioinflammation marker testing was important to risk stratification. It showed a consistency and continuity with the AHA-ASA stroke guidelines, primary prevention of ischemic stroke. In fact, also consistency with some of the same authors. This is the ATP3 guideline with the AHA-CDC guidelines as well. Patients are treated to different LDL levels depending on their risk classification. If you're in the low cardiovascular risk category, that's 0 to 1 risk factors, your target is an LDL less than 160. Moderate risk is 2+ risk factors. It's an LDL goal of less than 130. A high cardiovascular risk is LDL of less than 100, and very high risk could be an LDL managed all the way down to less than 70 milligram per deciliter. As you can see in the moderate risk category, testing for inflammatory biomarkers could reclassify the patient potentially to a higher level for more aggressive treatment. Building on this ATP3 recommendation, the expert consensus panel recommendation for the use of plaque testing shows further risk reclassification. Again, the low cardiovascular risk, moderate, high, and very high. The patient is tested for LPPLA2 levels. If they're less than 200, which is a good cutoff point, there have been publications at the 200 and maybe slightly above 200 for a cutoff. If they're below that, it's recommended to keep them as per the ATP3 guideline in both the moderate and high-risk categories. However, if they test above the 200 nanogram per milliliter LPPLA2, they are reclassified to these higher levels, suggesting higher and more aggressive treatment options should be sought. So instead of a moderate risk patient being treated to LDL below 130, they'd be treated to below 100. The high risk patient, instead of below 100, would be treated likewise to below 70 LDL. Published recently, this year, 2009, in Stroke, was a paper, again, this came from the ARIC study, which said LPPLA2 improves the stratification of ischemic stroke risk. Let me show you the initial classification of these individuals. This is based on traditional risk factor assessment. 86% were classified as low stroke risk, 11% moderate stroke risk, and 3% as high stroke risk. The stroke risk definitions for 5-year stroke are low risk, less than 2%, intermediate, 2 to 5%, and high risk, greater than 5%. Now, after measuring plaque values, as well as CRP, these patients can be reclassified as to their stroke risk. 11% of the patients in the moderate risk group were reclassified to high stroke risk. That is, they have greater than 5% chance of having a recurrent stroke in 5 years. You might want to consider more aggressive treatment toward these patients. On the other hand, 28% of them were reclassified as a lower stroke risk, which suggests that you should maintain the current treatment regimen and, in fact, be comfortable with this, that you're treating them adequately. Plaque test is not only useful in primary prevention, as we've just seen, but also in secondary prevention as well. This is some data from the Olmsted County Mayo study. The death rate 1 year after acute MI is 5 times higher for those with an elevated plaque value, as can be seen here. Similarly, in secondary prevention of stroke, it was shown in the NOMAS study, which is the Northern Manhattan Stroke Study, that high plaque value doubles the risk of recurrent stroke during the 4 to 5 year follow-up period. Also, this comparison to CRP speaks to the limited value of CRP's predictive value in stroke, as shown on the left, with a relative risk of only about 1. I'd also like to show you how therapeutic intervention lowers LPPLA2. Lipid-lowering medication has been shown to reduce cardiovascular events and also lower the plaque value. These are some common lipid-lowering medications, well used, well known. Whether it's statins or fibrates, they cause an LPPLA2 reduction of almost 30%. If you add niacin to this mix, niacin and statins, it's greater than a 50% reduction in the plaque value. And if you add omega-3 fatty acids to the statin, it's almost a 50% reduction. So you can affect not only their cardiovascular risk, but you can affect the LPPLA2 enzyme level in these patients. Here's some data from the PRINCE study, which shows that statins lower the plaque value independently of their LDL cholesterol lowering effect. There's very little association, as you can see, between the decreased LDL as caused by statins and the decreased LPPLA2 as caused by statins. You can see that in this chart, which is basically a scattergram with an R-squared value of 0.06. So here are your patient candidates for LPPLA2 testing, for plaque testing. They could be intermediate risk patients with 2 traditional risk factors, metabolic syndrome, or a bad single risk factor like smoking or age over 65. They could be high coronary risk equivalent patients that even if treated, they still may have unstable plaque. So when is the job done? When have you stabilized them and stabilized their plaque? Plaque testing could be used as a tiebreaker for borderline lipids. How aggressive should you be if the LDL is borderline 130 or the HDL is borderline 40? It could also be a tiebreaker for apparently healthy persons with borderline hypertension. You recall the risk for stroke might be 3.5 to almost 7 times higher than those with low blood pressure and low plaque values. Take Miranda here, for example. She's 45, a smoker. Total cholesterol is borderline high, about 200. She's borderline hypertensive, 138 blood pressure. And she has some family history of premature coronary vascular disease. So you assess her and you put her in the moderate risk category. You give her the plaque test and she comes back at 278, which, as we've said, is elevated. Now you reclassify her according to the algorithm as a high-risk patient and treat her accordingly. You might want to be more aggressive on her lipid management as well as other interventions. In summary, LP-PLA2 is a biomarker in CHD and stroke. LP-PLA2 is specific for vascular inflammation and is a circulating measure of the progression of rupture-prone plaque. Elevated LP-PLA2 plasma levels correlate with a doubling of risk for CHD and stroke in multiple published epidemiologic studies. Plaque levels can be used to identify patients who require more aggressive treatment, including lipid-lowering therapy. And finally, therapeutic intervention can lower LP-PLA2. As we've shown, the plaque test is an available product. The Diadexis plaque test for LP-PLA2 is cleared by the FDA as an aid in predicting risk for coronary heart disease and ischemic stroke. Simple blood test that doesn't require any fasting by patients. It's used on common automated clinical chemistry analyzers that can be found in most labs. Thanks for your attention. For more information, please visit plaquetest.com. Thanks.